nice to see a full house. Welcome back to our inter-holiday seminar series. And I'm happy today we have one of our own, Jonathan Weiner, from Health Policy and Management. Jonathan is Professor of Health Policy Management and Health Informatics, or Health Sciences Informatics, Director of the Center for Population Health Information Technology, which you'll hear about, and he's Director of the PhD Program in Health Services Research and Policy, and Director of Public Health Informatics Certificate Training Program. His general interests lie within the fields of healthcare policy and health services research and evaluation, and in healthcare and population health informatics. Specific areas of interest include health IT informatics as applied to population health and to quality of care, primary ambulatory care, quality of care, managed care and health insurance, health workforce planning, and so forth. He's the co-developer and team executive director of the widely used Johns Hopkins ACG case mix predictive modeling system, the most successful technology transfer or IP project in the history of the Johns Hopkins University, and used in over 16 nations. Jonathan got interested in public health informatics a couple of years ago and has been working diligently on creating the center, and we're happy to hear about it. Take it away.
Thank you, Harold, and thank you for coming. And I know there's a lot of people at home, so thanks for joining, either or live or archivally. And Harold, I am on this podium in part because of you, not only because you're looking to fill a slot today, so thank you for that. But also, many of you know I've been here my entire career, 30-some-odd years, although not known to many of you. I started out actually as a systems programmer in an HMO while I was in graduate school, but nobody would have called me an informaticist per se until maybe recently. But, with thanks to Harold and a lot of other colleagues in the room, I finally got it. I'm here at the Bloomberg School of Public Health, because I, like almost everybody in the room, are here to improve society, improve, in our case, as our dean say, a million at a time. Some of your case, a patient at a time for the clinicians. But I saw the light, and that's the light that I hope to share with all of you today, that without informatics, without health information technology, HIT, we can't accomplish it. And so the last several years, although I've used magnetic data since I started as an assistant professor in 1981, and I'm fairly well known for using, at least in this country, we have 100% of those insured have computerized claims data. And as an assistant professor back in the early 1980s, I worked with Octo Barnett and the folks up at Harvard trying to pull out data. And it was a challenge then, as it is now, data out of, I guess it was the Harvard Health Plan, or whatever they called it then, HMO. But today I am going to talk about our new center. Some said, well, is this the official unveiling? I think it's sort of an unofficial unveiling. Sometimes you open a restaurant and to the public at a certain time, but you invite your friends in early. So that's sort of here. This is so in the family. Many of you know that I've been talking about the so-called Center for Population Health IT, or CPHIT, both as a major activity here at the Bloomberg School of Public Health, and I'm pleased that that's where we're housing this cross-campus informatics symposium. But it's bigger than that. We at Johns Hopkins are leaders in so many different domains of public health and medicine, and many excellent informaticists and healthcare IT people. But we also have, and I'm pleased to see half a dozen colleagues from across Johns Hopkins, really excellence in many other types of computer science at APL and system science. And so I think we can be more, can be better. And so that's the vision that I have. Obviously isn't about me. It's about something bigger and ultimately in having an impact. So the title of the talk, as you can see, is Harnessing the Power of Electronic Health Records and Health Information Technology to Improve Population Health. Some of you could be up here giving the talk. Some of you said, gee, let's go see what he has to say, and haven't heard this talk before. So I'm going to spend the first 15, 20 minutes giving a view of what I think is happening. Some of you also know I tend to be very animated, move around a lot. I've been told I'm not allowed to move at all. So if it's uncharacteristic, it's because we're being taped. So I apologize for that. Probably more entertaining when I move around. But anyways, but in the first 15 or 20 minutes, I will talk to you about the first I got to get this to work. Okay. Oh, I forgot to say, no conflicts of interest on this. There's nothing that I'm talking about that has any financial implications that I'm aware of for the discussion today. But during the first part of the talk, I will discuss this, the huge opportunity that health IT is going to bring around. Now, I know it's not very green, but I do have some copies of the slides because I know that how many people download things all the time, not always. So there are some slides at both doors, or you can get them on the way out, because it's my goal, particularly for the second part of the talk, to leave behind with you a vision for what it is we're trying to accomplish and invite you to join in whatever way seems appropriate for you. This part, again, many of you are aware of. I really think we are on the tipping point or the Rogers diffusion curve. People have been talking about it for God knows how long, particularly some of the leaders in the room here. But electronic health records, we've gone just in the last several years from about 25%, 15% of doctors to 50 or 60% today. In a few years, we'll be at 75%. And in part because of President Obama's so-called high-tech stimulus package. People forget that even before health reform, so-called Obamacare or ACA, Affordable Care Act, was the stimulus money out the door. People talk about $30 billion. Frankly, it's more like $40 billion of federal money. And David Chin and others in the works with private industry have estimated it's really 2, 3, 4 times that. So in part because of the stimulus package, we have the biggest investment probably in the history of the world. I've done a lot of work in the NHS in Britain where they put a lot of money into HIT, 3, 4, 5 times, and I'm not sure that that's greater than what we've done. So this is well known to hospital administrators, to office managers in medical practices. It's not so well known to those of us in public health and in academia. And it is huge. It is huge, and it's a little scary, and there's a long way to go. So that's why I'm up here today. So again, I already alluded to this today in the presentation, and I will have pretty much a hard stop at 1 o'clock Eastern time for those of you watching us in other time zones. And we will then have question and answer, both live here in the audience as well as, I understand, Harold, just live. But people know how to reach me if they have questions afterwards. So again, the first part of the talk is what's happening. The second part of the talk is to give you a view of our vision for CPHIT and a sense. It's new. We don't have a lot of funding, although there's some funding thanks to Dean Clagg and my chair, Alan McKenzie. There's some startup funding, and we are very actively searching for more substantial funding. But we definitely have a vision, and I can give you some very specific ideas of what it is that we intend on doing. So those are the two broad agenda. Again, I've already talked about the so-called high-tech. I always forget what HITECH stands for, and don't worry. Again, well, you probably have heard of the so-called meaningful use, sometimes MOO or MU, and that is they were very smart. You're not being paid, what is it, $50,000, $45,000 a doc? That adds up when you've got a lot of docs. Or $2, $3 million per hospital. You don't get paid just for putting a system in place. You get paid for putting a system in place that can be used meaningfully. In fact, I have a whole lecture or even give a whole class on what is meaningful use. But at least it's a good concept. But most importantly, it has to be standardized, and it has to be able to communicate with one another through the health information exchange. Now, they screwed up that the people that wrote high-tech and the people that wrote ACA didn't talk to one another. As you might know, the two biggest acronyms in healthcare today are HIE and HIE, and they mean two entirely different things. The Health Information Exchange, such as CRISP, which I'll talk about briefly, is something in every region, once and for all, hopefully, all the doctors and hospitals will share records across one another. Sometimes people call it HIO or HIO for the old regional health information organizations, but some of you, unless you're in health policy and management or on the insurance side, may not know that the Health Insurance Exchange, sometimes called the Benefit Exchange, sometimes called HIX, H-I-X, to keep it straight. That is the place that most uninsured Americans will be getting their health care. It's very confusing, but today, unless I screw up, which I do sometimes, when I say HIE, I mean the Health Information Exchange. This is huge. I'm not allowed to use my laser, but those of you that have, that's because people at home aren't seeing the screen. The stages of meaningful use, which rolled out this year. It's a P for P, pay for performance program. Our healthcare system, as you might know, is fee for service largely. That's its weakness and its strength. But so the best way to get into doctors' bank accounts is through the direct wire that the Medicare program, CMS here in Baltimore, has direct wire to all doctors and hospitals in America. So they get a bump up for their fee-for-service payment, wink, wink, if they meaningfully use their EHR. This is profound, put in place by David Blumenthal, the head of the Office of the National Coordinator. Also, it's actually run by CMS. It's officially, this is their logo. Some of you may not have seen it before. I can't read it exactly, but it's Connecting America for Better Health, the EHR Incentive Program. That's the Meaningful Use logo, run by people here in Baltimore. First, they have to have a structural system, then they have to have process of care, then they have outcome of care. Again, if you're not familiar with it, this is huge. The biggest, frankly, finance, management, high-tech information in the history, I think, certainly of the U.S., probably in the world. And this is what I alluded to, the tipping point. This comes from the CDC Center for National Health Statistics. 50%, this was in 2010. And again, this is amazing. Just as recently, at this period of time, you'll see that we were much lower. Of course, what doctors do with it is why one of the reasons we're all here. Simply using it as a word processor is hardly full implementation. But again, that is one reason that we're here. It's not even about just necessarily the one patient, although if I'm that patient, or if any of you are that patient, or the clinician, we want to do a great job. It's about adding value to society. And again, that's the focus of our talk. Again, some of you have seen this. It may be a bit of a review. You can look at it on the slide or the handout. It's my attempt at representation. In red, the core, the electronic health record, the provider, the patient. That's sort of the classic. That's not population health informatics. That's medical informatics, clinical informatics, doing a good job, helping care, not killing the patient. Some of you have heard the term we came up with, iatrogenesis. You click. I ordered the wrong color the other day on Amazon. I'm not making that up. I do that all the time. But some of you that are clinicians, you click on the wrong part, you can actually hurt the patient. So this is pretty serious for those of you interested in safety and quality. Of course, for every time that you can do harm, there are 20 times that the computer got your back and make sure that we're providing good care. So like everything else, it's flip side. But what I want to highlight to you, people will often use the term e-health, or HIT is the preferred term for the federal government. When they say health information technology, they mean all of these things. The EHR, if I can find, this thing isn't coming. There it is. The EHR, the electronic health record, the computerized provider order entry, CPOE, POE, that's e-prescribing, that's lab entry. Again, that's you click. It isn't just putting something in the record. It's having an impact on the patient. The clinical decision support. Gee, doc, you really want to do that? Or look at the Bayesian principles behind it. Increasingly, e-health, m-health if it's mobile phones, cell phones, personal health record, PHR, take your pick. But we've got to think about it holistically. The patient, even a very sick patient, spends what? 2 hours a year with the doctor, 3 hours a year? How many times do they spend online or have that smartphone in their pocket? Quite regularly. And so again, this is huge and growing. We need to view it entirely. Big organizations let the patient into their EHR. They use the term web portal. Geisinger, I think we're developing one as we roll out Epic 2, Epic as well. And that is, although maybe it's Epic 2, 3, or 4, I'm not sure. But I think that the integration of all of this is huge. Now, the part, and let me click on the next one, where CPHIT, the Center for Population Health IT, comes into play, augmenting our clinical informatics colleagues, is really off to the left and off to the right. So off to the left, we have public health agencies, managed care plans, again, which are huge as part of health reform. Half of the uninsured are going into Medicaid plans, all of which are sophisticated. Again, we have a huge Medicaid plan here, Johns Hopkins Healthcare, very sophisticated. So managed care is, quote, not necessarily the bad guys or the enemy. It is U.S. healthcare. And then, of course, ultimately, society, policymakers, employers, whoever pays the money. So all of this are key parties in the process, and some would say should be really the lead of the process from a societal perspective. On the other side, we're in a preeminent scientific institution. Whatever it is we do, we add to the knowledge base. In the future, there is probably no public health researcher and no clinical researcher that will not have a significant component, if they don't already, in developing the evidence base, generating knowledge, using analytic technique that does not come out of the EHR or the eHealth apps. But you'll notice that these are two directed arrows. Where do you think clinical decision support gets its probabilistic statistics? How do we know that this patient should or shouldn't get a certain drug? From the science. And we will be irrelevant to the future of science unless we digitize and make it relevant to the fully automated healthcare system that we will have one day. Moreover, for those of you familiar with the Vioxx situation, we can learn. Will a randomized control trial go away? I'm not sure. I don't think so. But when you have all information on all patients at all times in real time. Will we be doing research in a different way? I think so. I don't even want to get into the genetics quite yet, although I think the next slide touches on that. With biochips, what are they down to? $1,000, $2,000, $500 to get key genetic information. Right now, there's only about 16 pieces of information that help the clinician, I understand, BRAC, yes, no, whatever. But one day, it's mind-boggling, all the information that can be linked to the EHR. In our public health school, we can't forget about environmental factors, geographic factors. There's a collaboration with Brian Schwartz and Geisinger up in Pennsylvania, where they're actually getting particulate matter and geographic information and linking it in to the patient's EHR. So again, even those of you that don't use computerized records per se, I think one day as things are digitized, it will be very large. So all of this will be linked together across communities with public health agencies, hospitals, consumers in one geographic area, such as our Maryland CRISP. CRISP stands for the Chesapeake Region Information. It's the cute crab on the computer. I'll share that in a moment. But every region with federal funding, hopefully it can be sustained, is pulling together slowly information across. One day it will be across the world. But again, right now I'll settle just for Baltimore. And this is here is the CRISP logo. I thought there was a computer somewhere, but I downloaded this offline. But here's an example in every state of the health information exchange. This one doesn't even include public health on the chart. The physician's office, the hospital, the health insurance plan, that is including the other HIE, the insurance exchange, and this is what the interplay is. Those of you interested in encryption, in exchange of data, in ethical, in legal, it's huge. It's huge, and that's a lot of the requirements. But one day, and it won't be that far off, a few states already have it, all of the information from all of the patients will be centrally located and can be used for population purposes. This is another representation, again, done by the CDC since it's very public health oriented, and here we have all the federal agencies, here we have all the federal providers, but I like this. Instead of CRISP, they have the public health in the middle. Public health in the middle. So the point is that whether or not, and here I'm very pleased to say they understand the needs for analytic, they need ontology, vocabulary. As many of you know, most of the records have 15 different ways of labeling diagnoses. We thought we had it under control for claims data with ICD, but the so-called free text and SNOMED. So all of those challenges are huge. And that's a whole other topic for another discussion. And it's why I'm so glad some of the experts in data mining, natural language processing, and text mining from our Homewood campus and APL are in the audience. And if we're going to put this forward, we need experts like that in the field. I'm moving quickly because I want to make sure we have ample time for questions. This is a great slide. I don't know if Anna Arlova's in the audience or perhaps at home. Hi, Anna. The Public Health Data Standard Consortium, some of you know that organization has been leaders in making sure public health is at the table. So this is a representation, it's sort of neat, of the Health Information Exchange. Again, some have started using the old name, the Regional Health Information Organization, or RIO, to distinguish it from the other HIE. But this is an example, and you can, I believe, download the slide and read it better than you can on the printout, but talking about all of the clinical data, all the public health data, how one day the public health information conventionally done, today in vital record systems will be linked with the EHR. Many of you know that there are many excellent in our state and other states public health agencies. They're so busy with all the required stuff, vital records, surveillance, and as you may or may not know, what is it, 50%, 60% of their budget is actually spent not on public health at all, but on medical care for our uninsured and disenfranchised. So one day, if in fact we do have health care for all, we'll see what happens at the Supreme Court, public health can move toward this vision of ensuring that these public health data and, while we're spending 5% of the budget on public health, we spend 95% on the budget on medical care. And as a professor of health policy management, I can tell you a little bit about that side. What are we up to? $9,000, $10,000 a person, 13, 14% of the GDP, even though we have 50 million uninsured. No country comes close. That's where the resources are. And so when you hear me talk about population health, it's because I'm concerned with the health of the population, not just public health systems. So if you really want to find change, it's going to be with that 95% of the budget, so that the Johns Hopkins Health System, and it's so exciting to see that, as it moves toward accountable care, they are the public health agency. They're the population health agency. Again, that's a pretty audacious goal, but it is happening slowly, and that's part of the continued presentation. And that's what this is. This talks about the shift from fragmented care to coordinated care, the ACA, the Affordable Care Act. It used to be called the PPACA, but it sounded, PPACA sounded too much like alpaca, so they changed it to ACA. But as you know, it's mainly about giving people an insurance card through the health insurance exchange, but it's also about transforming care. And every bit of that care transformation is about HIT, Health Information Technology, and it is, from my perspective, about population health. Because it's basically providing value to the entire group of people who get care or are enrolled in that HMO, ensuring that, yeah, it's great that someone gets excellent care in the ICU, and I want that, for me or a family member if that happens, but if they shouldn't be in the ICU in the first place, what kind of good care is that? Or it's great that the clinician does a fantastic job on his or her diabetic patients, which they should, but what about the 30 that never step into the clinic? For every 10 that does. So I think it has to be from fragmented to coordinated, from provider-centric to populations, paying fee-for-service bits and pieces. No other system in the world really does that. But paying for value, paying for outcomes. I'm not going to read all of this, but basically healthcare is shifting, it's transforming, it is moving to populations, it's very exciting, and that is also what CPHIT is about. And this is, I couldn't believe it when I downloaded this from the CMS webpage. This is what they call their medical home. There's accountable care organizations, there's medical homes, you've heard about HMOs, integrated delivery systems. But if you read around this ring, say, hold on a minute. This is from the Medicare program about how primary care doctors should practice in the future, or is this for an HIT talk? So they envision that all of these things, virtually every one of these things, this was not from their HIT page. This was from their standard page that they're sharing with the Doctors of America for their vision, how primary care practice should be in the future. Okay, so we need to be moving quickly, but we have about 25 more minutes for me to sort of unveil and describe. Many of you have heard it, but to give a picture of our Center for Population Health IT. And we already are pretty good. We can always be better, and those of us that have been around here a long while know where the skeletons are buried. But still, this is a pretty special place where we have expertise and strengths in many different arenas. And as I mentioned, and I'm pleased friends from APL have joined, and friends from engineering, and all over, particularly when you take the whole, and we're not whole very often. So it's great to have a project, and this is one of them, that we really can and should be the leaders, many places in informatics, but today I'm talking about population health informatics. And the goal of the Center for Population Health IT, CPHIT, is to coalesce. I've been here long enough to know, here I am, everybody do what I say. Yeah, right, that's not how Hopkins works. It can't be hierarchical. It's got to be collaborative. People have to want to join. It has to facilitate. It has to work with dozens of other units and centers, and that's our vision. Again, either easier said than done, but with vision, with leadership, with resources, I'm not naive, and with things to help throw into the stew, that is the goal of our CPHIT. So the mission, and again, this will be downloadable. We're working hard on our webpage. I have material I can share with you. I have hard copies, so you don't have to get every single word. But our mission is pretty broad. It's to improve health and well-being of populations by advancing the state-of-the-art of health information technology and e-health. The terminology is confusing, but I'm talking more about the broader systems, particularly EHR-focused, both in public health agencies. That's a no-brainer. We have to provide some leadership in public health agencies, both in HIT and beyond. That's a whole other topic. But particularly with the new accountable population-based healthcare systems. And the specific focus, as I've already alluded to, is the application of EHRs, PHRs on denominators. Sometimes it's classic communities. There's very little health care in America that's given at the geographic level. And as most of you know, some of you may be colleagues from local or state health departments, they're just barely hanging in there, even the best of agencies. So the goal is somehow to find populations and maximize the benefit of those populations, and that's what will distinguish this center. It's not to say that other informaticists don't do some of this. They do. But the main goal of our clinical informatics colleagues is to do a great job for the patients in front of them or the patient cohort cared for either by that clinic, that unit, and sometimes the institution. We step one step back further to think about the entire population, including those that aren't necessarily coming to the healthcare provider, and even broader than that, society. So again, some of that's subtle, and sometimes it doesn't matter, as long, but it does matter if you put resources in effectively, inappropriately, and not get the big picture. But we'll come back to that as needed. So some of the things that we'll do, people are like, Jonathan, that's great, that sounds good, but what is it you're going to do? So I will, as the rest of this presentation goes on, attempt to give you, more detail about the specifics. Again, this is still unfolding, but first of all, I really hope that this can become, a national, if not global. By the way, I and the Department of Health Policy Management specialize in the United States and other high to middle income countries. We do a lot of work in Europe and Asia. And I do certainly know here at the Bloomberg School we're leaders in lower income countries. But I envision that first this will not. I have many colleagues from international health here. That's great. So we'll work closely to figure out. I know that the mHealth Collaborative and other global initiatives are doing a fantastic job, particularly, as you know, the most common computer chip in developing country setting is that little Nokia phone in the clinic manager's pocket. Obviously, as more and more PCs and other systems come into play. So this will focus mainly on the U.S. and higher income countries. We will do research and development, but I've learned, and sure we'll go for grants, but with a 10% pay line or even 15% pay line, if our only vehicle for moving this forward is waiting for those NIH grants, we're going to be talking about this for a while. But again, I've been at Hopkins for 30 years. Obviously, whatever it is you do, you've got to also go for those grants and NSF grants and ARC grants. But the goal is to develop a core. Some of you know we did go for a ONC stimulus money core, the so-called SHARP grant. In fact, many of you, we became friends, nothing like $15 million to invite a few people to the party. We came close but didn't get it, but I think that type of core money is we are seeking. As I mentioned, the dean and our chair, Ellen McKenzie, graciously provided some initial funding, but we are trying to look for some very serious core funding through foundations and other manners, because we know that we need a core. We're hiring new faculty. We got permission from the dean. Again, thank you, Mike. He wanted to come, but he's traveling today. But maybe he's watching me on archive. And we are hiring 2 new faculty. I think for the first time in history, we've hired Suchi Saria, who's probably watching from Boston, a brilliant recent grad of computer science from Stanford, who's the first faculty member joint that I'm aware of between the Whiting Computer Science Department and also Health Policy and Management in Bloomberg School, and we're looking for 1 or 2 other faculty members. But our goal is not to hire 22 faculty members. Our goal is to take all of you and the hundreds. In fact, there's not a single person in this building whose careers won't be impacted in some way in the future by the issues I'm talking about. It may be in 5 years, 10 years, 50 years, but it'll happen. So obviously, it's about bringing faculty together, coalescing them. And we will do research both at the CPHIT Center as well as collaborating with others. We also believe that, to talk about, I think that Harold mentioned our so-called ACG system. I and a late colleague, Barbara Starfield, with a lot of help from our friends, many of whom are in the room, developed this case mix predictive modeling tool that uses claims data, EHR data, to deal with, I think it's about 100,000 factorial. That's a lot of combinations. And we made it easy using EHR data, and it's widely used for payment around the world. And I have new appreciation. The article that I published that I get 10 emails about and helps me get promoted, that's good. But knowing that every day 80 million people are impacted by something that we do, I understand that has to be, how can you do information technology without working with vendors and industry? I know there's some dicey issues on that. But so we do hope this to be a model, and I'll show you in a moment, for working with technology transfer and getting things out the door, both through, of course, people have to get promoted and that scientific peer review is important, but also using other technique. David Chin, I alluded to David. David, who's sitting up front, recently joined the faculty. David's a MD and was one of the lead medical director at Harvard Health Plan some years back, but he's worked with industries as a principal with PricewaterhouseCoopers, and we're very happy to have him helping us understand how to work with industry. So thank you, David. And so we are going to develop, I'll show you a little bit more, again, somewhat new. We don't always do as good a job as we should. Mary, and I'm happy to see you in the front row, someone that's blended, both academia and industry. But I think that we have to get that right. And obviously the whole educational mission is central. Harold has converted me, although that wasn't so hard, Harold, given our backgrounds. But still, converted me to be the head, and a very committed head, working with Ed Bunker and others, for now the informatics certificate program in public health here. 40 students. It must be one of the biggest programs in the country now, from 0 2 years ago. And phenomenal resources. Some of you are in the room, and actually a lot of you are at home. So I think that this is all part of the vision. So you're still saying, yeah, I want a little more. So, Jonathan, what is you're going to do? Well, what it is we're going to do in part is going to be based on what makes sense and what all of you think is appropriate, and of course what our clients think is appropriate, be they health departments, be they HMOs, be they either type of HIE. But these are some of the ideas that we've had. We must develop, just like doctors are talking about developing indicator panels about their patients, and hospitals are thinking about developing metrics on their populations. Someone has to be out there looking at the community, the entire population, where are the problems, where are the challenges, something that, from a societal perspective, whether or not it's a accountable care organization or a state of Maryland health agency or the Indian Health Service, but somehow all of this huge amount of information has to be capitalized for what we might have previously called needs assessment. But now, since it's real time and since it may translate into actually improving health, it's a lot more than, quote, just a needs assessment. I put it up front because of, we are one of the national centers of excellence for natural language processing, text mining, data mining, and the great folk there actually aren't doing so much health. And as many of you know, it is a real Tower of Babel in that electronic medical record. If any of you have actually looked at the medical record that's been in place for many years, a lot of it is just basically a digital attic of information, and that's a little scary. On the other hand, if you force doctors and nurses to put every little thing in a box, check off this box, follow this line, they burn out in what, 3 days, 2 weeks? I'm not sure. But so, what is the answer? Part of the answer is work naturally. Just talk. Just type and let the text mining, the data mining, the NLP take care of it. A huge challenge, and one particularly I hope we can capitalize on from a population health perspective. I think that an area that interests me, I've been involved, a leader maybe even in using claims data. I mean, they're meant to pay bills, but they've become, in the last 20 years, the way we measure quality, for better or for worse. Our case mix system, the ACG, actually grew out of that. But we now have to use the EHRs. We've coined the term e-measures or EQM, electronic quality metrics. Not so easy. It's not so easy. Think of all that information. Gee, doc, that lab test came in 5 days ago, and it shows the patient is really in trouble, and you didn't even look at it for 5 days, and you took action in 10 days. All of that is digitally known. Do we use that for measuring quality? No, we don't. And one day, scary perhaps, but real-time challenges will be putting the beeper, I guess it won't be your beeper, your iPhone, what's her name, Siri, will talk to you and say, Dr. Siegel, that patient of yours is really in trouble. Click here and we'll send look at this lab result, and if you concur, we'll send the Chad Bolt's guided care nurse out immediately to look at it. There's really no excuse that we don't develop systems like that. Now, is that going to be easy? No, it's not going to be easy. But, we should be leaders in that. Some of you know our ECG systems for identifying high-risk populations. I guess that's the classic. The Johns Hopkins Healthcare, Martha Sylvia, Linda Dunbar, I think, are in the room. All the great stuff they do of trying to, all right, you've got 50,000 patients, or let's say 10,000 patients with diabetes. All well and good of giving everyone a private nurse, but that doesn't work that way. So can we identify who is in need? A little bit alluded to before, and develop an appropriate pyramid and appropriate care for each level. So that too needs to be translated to the EHR. Again, you'll see a lot of this that part wasn't conventional public health, more the population health. Now, this is moving into conventional public health, and again, we all need to do a better job of working with public health agencies, state, local, federal. But we have to, through the Public Health Data Standards Consortium and collaborators here regionally and nationally, need to really try to get it right as these EHRs and health information exchanges and health insurance exchanges are in place. How do we all work together from a public health perspective? I'm very pleased that in the meaningful use criteria, there at least was a placeholder. There are 30 different things docs and hospitals need to do to get paid. At least the public health people were at the table because I think there's one public health meaningful use criteria they have to choose out of 3. Better that than none. And what they are, to the best of my recollection, is can they send immunizations to the public health department? Can they, and at first they just attest that they can. There's no proof. Can they send, I think it's a surveillance, reportable diseases to the public health department? And the third one escapes me, but I'm sure someone can help me with that. But right now, that is the only, just simply the ability to communicate with the public health department is where they are now. So they're not quite up to this vision that I'm describing, but it will happen one day. Decision support, clinical decision support is huge and growing. Some experts in the room, I know Harold works in this domain. Both laymen's work in this domain in different areas, making sure that the baby in the NICU or the cardiac patient is getting good care. We need to develop these systems for nurse case managers, for public health agencies, for the doc, that she is responsible for managing their 2,000 patients. One day, by the way, as the patients get the Siri to tell them to watch out for their blood pressure, or these indwelling biometric devices. I haven't talked about that. Intel and GE, 2 small companies, have partnered together to put an iPad, they don't call it that, they call it a health buddy or health guide, in every person's house when they get a certain age, and that will be the health manager of the household linked to your blood sugar, linked to the scale, particularly if you have congestive heart failure. Clinicians appreciate that that's pretty important. Keep the Japanese away or they'll link it to the toilet. And if you've been to Japan, those toilets will do everything. I'm not joking, actually. They can do assays. So one day, the role of the clinician, the role of the entire team will be very different when the computer will have all that information digitally. By the way, there's no need for the care to even be proximate. The clinician, I know they're very upset at Harvard that the Harvard grads that went back to India in radiology were reading the MRIs. You hear that story? So I think one day, those digital representations of the patient can go anywhere. So we've got to, back to this, the CPHIT has to get this clinical decision support system, not in the conventional. In fact, I've coined a new term, or maybe others have used it, but population decision support system. So it's not just for the doc, but really sort of real-time management for the entire system. We've worked, we have many leaders here in ethics, Nancy Cass, Ruth Faden, and others, all kinds of ethical principles and challenges. I mean, someone asked me the other day, Dr. Weiner, this is a student in the class, why is it that an HMO or a hospital is selling my data to a pharma to do research? Yeah, I know my name's not there. Or gee, I'm trying to do, health research to benefit society, but doctors and hospitals say they don't want to participate. And, not to mention all of the confidentiality. So both legal, ethical, and of course we have all those encryption experts at the Information Security Institute. We all need to work together, and there's no reason, given the resources that we have here, we can't be the national leaders, between the ethics and the encryption and our friends at No Such Agency down the street. I think there's all types of stuff. If it's my records, I want it to be secure, but I think that we have societal value. I mean, who pays for these records? It's not the HMO's dollars. It's not the hospital's dollars. It's not even the patient's dollars. This is either taxpayers' dollars or dollars that come through societal. It's very complicated. I don't have the answer, but I know that it's a challenge. I think that clearly we are first and foremost the number one NIH research institution in the world, and I think that, or at least the country, but I guess that makes it the world, right? But I think that how can we do research in the future without understanding how all of this data can to generate evidence, and it's not just new knowledge, but also how do we disseminate and translate that knowledge into the system so it can do some good. take a deep breath. There's a lot of work here, and this is just 10 ideas that we've come up with. Let me, looking at the clock right here, about 6-7 more minutes, and then I'll switch it over to discussion. But all right, you're starting to get a flavor for what we have in mind. How are we going to do it? Well, when we put out this show called SHARP grant, which was a grant for research in related themes, it wasn't the exact theme, we had 60, 70 colleagues immediately signed up. So I'm not sure we'll get 60, 70 tomorrow, but I think that with a vision, and part of the vision is we're starting off with the SEED grant program. We have identified some money for that, both from a colleague, Greg Hager, in computer science, and also from CPHIT funds, and we have had some discussion with corporate. We're working very closely with our colleagues at Johns Hopkins Community Physicians and Johns Hopkins Healthcare, our own HMO. By the way, we're one of the few academic health centers in the country that also have an HMO. Johns Hopkins Healthcare. I see various collaborators here. I'd like to think that we've been helpful to them at times, and I know for sure that they'll be helpful to this because they've got, 300,000, 280,000 patients? Not patients, sorry, I slipped. People, consumers, denominator, and they get it. They know that, a patient in an ICU cared for well, that's a success. No patient in the ICU at all, that's a greater success. And with all due respect to the great colleagues across the street, and if I ever have to be in ICU, I hope not, that might be an okay place, but not being there at all, as Don Berwick, who was head of Medicare and Medicaid until last week, was it? I think he had to step down. He said there's absolutely no value to health care intrinsically at all whatsoever, period. Then he went on to say the only value is what it does, to improve that person's life and or to add to their joy and well-being. I thought that was pretty profound to the most important payer in the entire country. So I think that, sorry, I'm jumping around, but I do think that working with our denominator health plan and others, they get it. So as I've already alluded to, CPHIT isn't, can't possibly say, okay, everything that has to relate to public health or medical informatics is going to be through CPHIT. Of course not. But Scott Ziegler, when he was chair of Biostat, convened what was often called the Ziegler Report, where he shows interlocking centers and programs that would try to coordinate and convene. I'd like to think that this would be an important convener, and if we have more resources, maybe something more. But again, the Johns Hopkins Healthcare and Johns Hopkins Community Physician, the biggest primary care network in the state, I believe, and also one of the most sophisticated within Johns Hopkins Health System, and the state with computerized records. We're working to develop a joint database. Again, we're not there yet, but announcing it in public may add more pressure for all of us, something that would benefit the HMO, something that would benefit the patients in the primary care setting, and would be a vehicle, Harold, you call it a sandbox often, with HIPAA-compliant data that we can use. I was working with some Blue Cross plans that gave us no money. They simply gave us claims data with a very unusual deal. It was, this is HIPAA compliant, you sign that you're going to keep it safe, but you can do whatever you want with it for research. Jody, what was it, 40 articles we got out? 40 articles with no funding just by providing data? I've been astounded at that. And I mean, among you, the assistant professors and associate professors are the engines of this institution when it comes to peer review. So that is my vision. I also hope that we can work very closely. As you already see, it goes without saying, and I've acknowledged several times, we have colleagues from the business school here, great MIS, HIMSS type of expertise there. We've got, many of you know, Patty had to travel. She said she was going to be watching it online. Patty Abbott from the nursing school, Martha Sylvia and others, and other colleagues from the nursing school. Goes without saying, in engineering and APL, we can't begin to do this without colleagues there. A few who have worked in health. Joe Lombardo is a national expert on biosurveillance, but most of whom haven't been working so much in health informatics so much. So again, and Tak, Tak, I have a hard time with your last name all the time, but Tak, who's heading the Systems Institute, and at Homewood. So we have a lot of opportunities. And again, I already mentioned that at first I hadn't planned that we would do developing and lower income countries because that's being handled pretty nicely with some consortium. But clearly we will work collaboratively. These are some of the disciplines. You can look at that. We're blessed here at Johns Hopkins with pretty much every discipline that you would need. Yeah, we do need some more clinical informaticists, and we do need a few more in various areas. But half empty, half full. I think we're 3/4 full. This is important just to highlight a little bit. In red, the CPHIT, but acknowledging that we're part of a complex organization. Of course, our health system growing by the day. What is it, a $600 million investment with Epic? So many academic departments. We hope to work with a lot of external organizations. We also hope to set up an entity that will be a vehicle. Of course, CPHIT will be a not-for-profit regular academic center, part of the Bloomberg School, but maybe one day it'll be an institute, but that's not my goal right now. But we hope to set up an entity held by the institution that will provide a vehicle for technology transfer right from the start. So we, of course, need some benefactors and grant agencies. That's conventional. But we also hope to develop business partners. And so, again, not perfect, but as mentioned, our so-called ACGs are the biggest technology transfer experience in the university. And so both positive and negative lessons, I think that I have great appreciation for that as an option. I think that we've already talked about most of these collaborators. And I do look forward to discussing, because so many of you have great relationships, and so many of the people out there, whether or not it's military or agencies or vendors, or I got a fantastic call the other day from a network of the leading. It's called the HMO Research Network. What is it? 15, 20 leading institutions that all have EHRs, and they heard about this and they're very interested in. Of course, it has to be a quid pro quo. By the way, we hope to work very closely, and we've talked with Stephanie Reel and Peter Green, our leaders, and others here to make sure. Now, granted, their goals are different than our goals, but that we work really closely with the Epic rollout and all types of activities here. But to be honest, it'll be a while till we here at Johns Hopkins, other than a few pockets, have a 5-year seasoned, that's what it takes to do research, or a 3-year seasoned database on a large denominator population with all health care and all preventive care in that. Let's be honest, that's not Johns Hopkins today. I hope it'll be tomorrow. So in the meantime, we do need to collaborate with not only public health agencies, but others, such as Geisinger and other organizations that do have such a database. So I think right on time, I will end. Again, just real quickly, you can look at this. I mentioned the Sea Grant program. I mentioned the data. I mentioned the new faculty. You guys are less interested in the industry council. Unless any of you are either online or here from industry, give me a phone call, because we hope this to be a national model. I visited the MIT Media Lab a few times. That's a model at MIT. They're the leaders in tech transfer, and they actually have silver, bronze, platinum relationships with different industry who love it. It'll be a while till we get like that. But the goal is that, we learn from them, they learn from us, they help support us, they make money from us. I mean, that has to be a relationship. I know it's challenging. We're not experts at the School of Public Health at that. But if we get it right, I think that has to be part of it. So we'll end on I don't know if it's a happy note or what note. So will the application of health IT to population health be easy? And so this says this is where the idea of the EHR starts getting complicated. So maybe I'm right here right now, but I'll need your help to grapple with all of this. So we have a web page that is about to come out, not ready yet. For those of you that are not physically in the room, apparently you can't ask questions now, but those of you in the room can. My name and email's there. We're lucky Elise Lasser is our coordinator, trained here at the DHSI. So one of us can help you with any questions. And in a few weeks, we will have our web page up. And it's my goal over time to all of you to make you want to participate, because we're doing such a great job. That's the only way anything succeeds here at Hopkins. I know that's a challenging goal, but hopefully you share some of my excitement. And I'm pleased to, officially unveil and announce, at least to the Hopkins community, our vision. So thanks for coming. And we do have about 15 minutes led by, Harold, you can MC it and let people ask questions with the microphone. So, you have to use the mic. Thank you.
Here's your opportunity to talk back. Yeah. So, anybody has specific questions? Can you? I'm not sure. I have an interest in methodology, and I just wonder if you can speak. I saw statistics, and I'm not sure about it. You had EPI buried in there. Can you say something about efforts to get applying the methodologies of biostat and EPI, how they need to be brought to bear to the analysis of
Sure.
the HR data?
Well, it goes without saying, by the way, that everything, although I'm talking, I guess you would say, above the line, on the policy and big think issues, we're Johns Hopkins, and I know that, we've got to get methods in general right. And what people were really sure, they might read a white paper and like our ideas, but what they're really going to want from us is tools. So just in general, it goes without saying that methods are key. Now, specifically, the EPI and biostat, I have met with Karen Bandian Roach and Carlos is representing EPI and others. So we do fully envision to find collaborations. Again, when you talk about, people often say, yeah, I do analyses, that's informatics. And as you have taught me, that isn't always the case. So obviously we have a lot of analytics that goes on, sort of separate from informatics. Do you need good, HIT and informatics system to feed analysis? Absolutely. And are the two, interrelated? Yes, they are. I'm not quite smart enough to know where the lines are or aren't. If there are any biostatisticians or other analysts in the room that want to help me where the lines, where we have collaboration and where we have distinctions, that would be a good comment as well. So that's the best I can do, Harold.
Jonathan, I have a question. I noticed that you started a center. I just had earlier this week a big discussion at some other university what the right way to start is, with center or department. Can you elaborate why you didn't go for the department?
Well, because first of all, I don't see anyone open. Now, this doesn't preclude. I know I've been around a while. I understand, the discussion of, probably in the medical school, a department of informatics. The first thing on the list would certainly not be this. In our context, we don't do, the public health school, the departments, if anything, getting smaller, not bigger. And I hadn't planned on moving outside of the public health school. And for all the reasons I mentioned, the sum of the parts are pretty great. So I wouldn't begin to do this without people from about 10 or 15 different departments. So that thought didn't cross my mind. That does not mean, and that shouldn't preclude, in the institution, although I wouldn't see it in the public health school. I don't think that would be the case. A department that would strengthen some core resources. So I also think that, our department, for example, in health policy management, is bigger than 60% of all entire public health schools. So I think part of it is, to start a department with 3 or 4 or 5 people, which in other institutions might be pretty cool, and I'd be happy for 3 or 4 new colleagues. Just doesn't make sense in a school with 200 faculty in a department. So we can continue that talk, but that's my quick responses.
Very interesting presentation. I happened to see one of your slides which mentioned something about the international relationships. So could you please tell me more about your CPHIT relationship?
Sure. I'll let Elaine and Bill and Ed, these are colleagues in the room that are more expert on international. I think that, we're blessed here at the Public Health School with expertise at different levels. So because I don't have the expertise and there's other efforts going on focusing on e-health, m-health, and developing country context, I view us collaborating closely. We're both trying to get off the ground. They've had a little bit of a head start and are doing a great job. Now, I personally do a lot of work in 16 different countries, mainly high income, and so we meet in the middle. As I was reminded from people in China, people in India, and some Brazil, there are more middle-class people there sometimes than in the entire U.S. So there's a lot of different needs in some of these countries, but the needs in lower-income countries are so dramatically different. So CPHIT will work with higher-income countries, and we will collaborate closely with colleagues here. Now, one day, talk to me again in 3 years. If we decide to put it all under, one institute with 2 or 3 divisions, that might be possible. But I'm thinking big, but not that big.
Thank you very much, Jonathan, for the excellent presentation of the center. I have 2 comments or questions. One is regarding the experience when you will be focusing on population health. I think in our experience has been very critical the interoperability of all the information systems. As you point out in one of your slides, there are many independent information systems that are feeding the public health.
True.
And in our experience, even here in CDC, there are at least 600 independent information systems that they are not coordinated. Then interoperability of the systems will be a critical domain, I think, for the center, because legacy, this will be very good to have the electronic medical records, but there are legacy information systems that we need to put them in the site to have the benefits. And in my experience, one of my major challenge as director of the EPI in the Pan American Health Organization, advising all the ministers of health, was how we make this operational. And the major problem is that all these systems are running independently, and it's critical to show that it's feasible, a platform that will make communication feasible.
Absolutely right, and this is cheating. I have one box, everything that's here. That is, Anna Orlova, I think, did an estimate. I took it out of my slide presentation. I didn't have enough time. Was it 11,000 different vital and public health systems in this country, most of whom don't talk to one another? So you're absolutely right.
That's good. The second is you cannot mention the standards of the International Classification of Diseases. The ICD-10 has been a major problem in the country, and we are finishing the ICD-11. I think the center should be feeding some of the recommendations.
Let's talk further. Our ACG group is actually one of the ICD-10 experts on campus because we're already working with ICD-10 around the world. That's huge. Ontologies, hierarchies, classification, although very relevant, that's almost a full-time job. So let's talk further, and although we're knowledgeable and sensitive to that, I didn't see that front and center. But let's continue that discussion, both excellent points. We have, I think, time for 2 or 3 more questions. Albert, is that? You're not on. Is it turned on? Then if it
you never know. Okay.
Now it is.
So, I wanted to congratulate you, Jonathan, first for having the vision to put this together. I think that you're, in many ways, the first person in the country to put these 2 pieces together, even though other people sort of wave their hands about it here and there. So congratulations. To go.
Oh well.
To go back to your mission and focus slide, I was interested to see that research, the word research doesn't appear there. And maybe it's okay to go straight to improvement, but I was wondering if you want to talk about that. How much of this is development, how much of this is research?
Good point. Although I guess it goes without saying. Certainly on the second slide, you'll see research about 10 different places. But let me go back. Let me get back to you on that. Actually, we're all here to research to really do what's in the mission. We do the research because we assume, and anything that we do at Hopkins. But you raise a good point. Maybe we should make it a little more, more relevant. But this will definitely be applied research, as is much of the research in the public health school.
Hi, Dr. Weiner. Thank you for your presentation. So on the slide where you have the model of the left side and the right side, there's this issue about, I guess, clinical informatics and decision support in that way compared to the kinds of things that are more public health and broader research concerns. As a student in training, those things are very hard to separate in my head. So I would wonder. And
you're in medical school and you're trying to do public health, so you're a little schizoid with both sides.
Right, exactly. And as I think many of my classmates are, and this is like
well,
something
good. I'm
that
pleased that your medical school classmates are also thinking about public health. That's, I thought, rare. But I'm sorry, let's get to the question.
So the point is, I guess I just wonder if you could talk a little bit about the challenges in, I guess, connecting the two and kind of drawing the
great question,
real
but
distinction.
I think it's actually you guys in the future. I was very excited to give a talk to medical school last week, the week before, invited, and everybody in the room, all your age. It's a no-brainer to your generation of clinicians. I think that this all has to be together, particularly those that see the light. It was a wisecrack, but it wasn't. Not every medical student sees the light about the public health and the full vision. But I don't think there's any other way. Several people have said, I like this, but, by the way, the greatest joy I have is when someone looks at one of my slides and tries to improve it rather than accept it. So granted, you could explode any one of these boxes further. And this whole issue of clinical decision support, when is it just one patient? When is it all the patients in the clinic? When is it the entire organization? When is it the community? I'm not sure. we'll start on the outside and work in. Some of our colleagues have started on the inside and work out, and we'll meet happily in the middle. So that's the best I can say, but it must include all of these components. But clearly, some of what we do is not going to be as relevant, to the one clinician, one patient. I think we have time, perhaps one more question. But thank you. I hope we can continue that discussion. I know we will. Yes, Len. You got the bad mic. Sorry. Can someone give him the good mic?
It's a low resource.
You have a high resource.
Simulating developing country conditions here. But first of all, Jonathan, I do want to congratulate you and thank you for your leadership in this discussion. As you mentioned several times, there's a global coalescence around the realization that we're reaching a tipping point with technology and the potential that technology has in public health. I very much appreciate your generosity in reaching out to the other groups at the school and across the university, specifically those of us who are working in mHealth, who see this potential on a global scale. Recently at the Bellagio meeting on e-health, there was an interesting acknowledgement that e-health, if done improperly, could divert valuable resources and may even cause harm.
Good point.
And I think that's somewhere that Hopkins has really looked to for that leadership, to demonstrate evidence-based pathways to move forward in this space. And we have a reputation for calling things as they are and backing it up with good data. And so Albert's point about research and evidence, and I think all of us
absolutely
improving that base.
I didn't say it because I assumed it, but absolutely you're correct.
Right. So we look forward to working very closely with you and this Hopkins-wide initiative.
Well, we with you as well. And again, this issue, I know that there's an excellent cadre focusing on low-resource countries, particularly mHealth. Some don't like to use the word mHealth because some of those, the chips aren't mobile. But nonetheless, I think that clearly there's a resource-appropriate need. So again, thank you all for coming. And those of you at home, if you have questions, the email, myself or Elise, please contact us. The webpage, we hope, will be live in a couple of weeks or less, and we will be having other types of programs and seminar and reaching out. We'll have a seed grant program. It won't be a large number, but enough to hopefully get people. We've already started 2 or 3 collaboratives, one on natural language processing and data mining with our colleagues at Homewood. We have 2 or 3 other sort of consortium that we hope to get started with, and we hope also to get some databases, the HIPAA-compliant databases that with certain criteria people can access for Hopkins-based research. So be on the lookout for all of those things in the future, and thanks again